for supraclavicular block, we want to target the inferior trunk. That's why we talk about the corner pocket between the subclavian artery and the first rib. This is where the inferior trunk lies. And also we now learn to observe what is an incorrect spread. This is so-called the incorrect spread, not just for supraclavicular. When you inject, if you see the local anesthetic spreading away from the plexus or the nerve, don't accept it. You know you need to go further. So in this case, we push the needle further in. As we inject, we now see the local anesthetic within this compartment. So this is what we need to learn for ultrasound guided block, is the local anesthetic spread pattern. For infraclavicular block, there is evidence that a perivascular technique is all you need, so-called the U-shaped spread, posterior to the artery, X-ray artery. When it is posterior to the artery, it is a successful block. But when you observe the local anesthetic anterior to the artery, even you get a beautiful motor response, don't accept it because it's likely to fail. For X-ray block, this study looked at perivascular technique, and they find that with big volume, it makes no difference. And I find that in my hand, it does not work well, so that's why I don't do perivascular technique for X-ray block. I do perineural injections. Popliteal sciatic nerve block, what is the right way to do it? Do we always need to surround the nerve with local anesthetic? And we did perform this study just to check. We do find that it's more likely to get complete anesthesia and also faster onset with the circumferential block than a non-circumferential block. So what so-called the donut sign. So this makes you hungry. When we do the block, you saw a beautiful demonstration of popliteal sciatic nerve block. Where should we inject it? Well, now we know that when we inject where it bifurcates, the onset is faster. You don't have to wait for 40 minutes or close to an hour. The onset time is shorter when you inject it where it divides. So instead of injecting surrounding the nerve here, you inject it in between the two nerves and see the local anesthetic spread. But what we still don't know is what happened to the other nerves. Do we need to do the same for subgluteal sciatic nerve or the gluteal sciatic nerve? Because with these deeper nerves, it's more difficult to move the needle around the nerve and get a circumferential spread. So is it necessary? I think the future would have to tell us. What are the new technologies that are coming up? And why do we need more new technology? I think we realize that ultrasound, when we try to visualize nerve in a deep location, is not so easy. It's still a challenge. Seeing the needle tip is still a big challenge. So what do we do? I found this robot, first robot ultrasound guided nerve block in humans. Maybe that is the future, but I don't think so, because as you see, a human is holding the probe. A human has to interpret the nerve image and also local anesthetic spread. The robotic arm is just to hold a syringe and inject the needle. So we still have a job to do. There are now many big new machines, nice machines showing you the enhanced image quality. I yet have to be convinced that any of them would give me a good image for a sciatic nerve block in this patient. You are very blessed. You don't have many of these patients in your country. But I see just snowflakes. I don't know where it is. Some people talk about 3D. Is that the future? At this time, I don't think so, because if we struggle to pay for a 2D ultrasound machine, the 3D ultrasound machine is more expensive. Also, the transducer is big. Trying to use it in real time will be a struggle, and most of the study I've seen is really to look at local anesthetic spread, because now you can see how wide it spread, whether it's spread properly or not. So I don't believe this is in the near future. We'll use 3D. Needle visualization is challenging because when the needle is at a steep angle, the beam hits the needle, the beam is going, the signal is going away from the transducer. It doesn't come back. So now we have these needle guide, mainly for in-plane technique. It's good. But also there are echogenic needles. I show you a few examples, so I don't want to be accused of bias towards one company versus the other. So these you can see it at the tip. You can see even for the whole needle. So all those are very valuable, and it's true. For deep blocks, I do use it. For superficial blocks, I don't use it, obviously because of cost reason, but yes, they are helpful. But more exciting is the GPS system. And I don't see many GPS system in your country. I know that, I heard that because you are very smart. The GPS is in the brain. But we see GPS system everywhere in the country because people just don't want to think. But this is for the dummies. Because you have a box transmitting electromagnetic signals, and the transducer has a sensor, the needle has a transducer, has a sensor, and then for in-plane or out-of-plane, you just follow this track. It's a dotted line. As you move the needle in, this dotted track will advance. And then for the outer plane, you see this track, you just follow it. This is your target. But the operator still needs to choose the target. So it's already available on the market. There will be at least 2 companies making it. And this is something in development. It's not available out there using the optical reflectance spectroscopy. So what it is you don't even see the needle, but because of the sensor at the tip of the needle is able to differentiate whether it's a nerve, whether it's a vessel, or whether it's fat. And what it does is it has optical fibers within the needle tip, and one fiber will send off a range of lights. Some are infrared range, some are visible light, and then depending on the tissue, it would be absorbed at different wavelengths, and then it's reflected back to the needle and be able to display. So this is just a preliminary study looking at the amount of hemoglobin and lipid. For nerves, for muscles, you will have high percentage of hemoglobin, blood, and low concentration of lipid. Nerves, you have much higher content of lipid versus hemoglobin, so by that they are able to separate. So this is just the potential use of this technology in the future. I think finally, before we go to sophisticated machines and sophisticated technology, I think we need to pay attention to training, because if we are trained well, we will be able to do a good job. There are many things we need to learn how to interpret the image, how to acquire the image, how to use the needle as we go in, can track the needle and look at local anesthetic spread. So remember, the ultrasound machine is just like a piano. How good you hear the music, how good the outcome is, really depend on who plays the piano or they use the ultrasound machine. So that's why training is so important. There are artifacts that will fool us, such as this. And if you think what you're thinking is correct, you may be wrong, because every time when you see something that you think is true, you have to check many times. It may not be true. There are errors, particularly for beginners. There are many errors that we think we are seeing the needle tip, we think we are seeing the local anesthetic spread pattern correctly, but we don't. So those are the things we emphasize again and again. Check the needle tip, not the needle shaft. There are many low fidelity phantoms, like the meat phantoms. I use that. I don't have money to buy gelatin phantom, several thousand US, and even go to the cadaver lab is more difficult. So at this time, we don't have any data to show that high fidelity training models are better than low fidelity. Next thing is assessment. As the trainer, how do you know the trainee is competent or not? So now we develop, just like the surgeons, objective assessment tools. So for example, this is a task-specific checklist designed by experts. Look at the number of tasks that one has to do for a certain procedure. Another so-called the global rating scale that surgeons do use. Look at how they handle the tissue, how they handle the equipment. So those are helpful to assess competency. And then this is from the Israeli National Board exam. They use again the objective structure clinical exam. So it's very involved. It takes a lot of effort to set up, but it will be very good for assessment. For those who don't want human but a machine, we try the Imperial College of Surgical Assessment device. This is something the surgeons use. Look at the hand movement. by looking at the time it takes to do the procedure, the path of movement, the number of times of movement, it's able to differentiate who is a novice from the experienced. So these assessment tools are out there. So if you ask me what the future is, I think the future is bright. I believe that ultrasound is here to stay. It's just a beginning here. I think you will in 5 years' time, you agree with me, is here to stay. You would find that once you use it, it's very hard for you to not use it. For upper limb and lower limb blocks, I think it's very well established. It's not really a big challenge to us anymore, except the sciatic nerve that is deep. We still have to do work on the trunk and the spine imaging to define what is the best way to do it. New technologies are emerging, particularly how to find the nerve, how to visualize the needle tip or track the needle tip. I believe we need to spend more time focused on training and how to assess competency, because eventually outcome depends on how we perform. And I think by doing a good job, we can improve patient outcome. So thank you very much for your attention, and I again invite you to Toronto next year. Thank you.
I'm sure all of you will agree that two extraordinary things happened today. One, the extraordinary lecture given by a living legend on regional anesthesia. The other one was the extraordinary contribution done by Dr. Ravindra Bhatt to his patients. To acknowledge both these extraordinary things, may I request each one of you to stand up and give a standing ovation for both.
Thank you, Professor Chan, for your earnest, heartfelt and convincing talk.